Hey, how you doing?
Great.
All right.
All good?
Yeah.
All right. All right. Thanks, everybody. I think we'll get started here. So my name's Dan Olson. I'm in the Department of Pediatric Infectious Disease. And today I am going to be talking about Zika virus and some of the updates of what's been going on worldwide, as well as some of our studies that we're doing in Guatemala. And Edwin and I were supposed to do this talk, but he actually came down with an illness, and it's not very often that he actually misses a day of work. So it was a legitimate reason. We thought from an infection control standpoint that probably a good idea for him to stay at home. But don't worry, he and I have a good working relationship, so I feel like I can speak on his behalf. And so I wanted to talk a little bit about our site in Guatemala, about Zika in general. And one thing you'll see is that a lot of the lessons we're learning from Zika apply to many other infectious diseases, which I'll kind of mention a little bit throughout this talk. And I'll definitely try to leave some room at the end for questions as well. So Zika was first identified in 1947. I'm going to use my little pointer thing. Yeah, okay. So Zika was first identified in 1947 in the Zika forest of Uganda. They were doing studies where they would take monkeys, put them in a cage in the jungle, wait for them to get fever, and then see what they could find inside the monkey. And that's how Zika was first identified. About a couple decades later, it was identified in humans in Nigeria. And then over the next several decades, there was a smattering of cases in Southern Asia, Southeast Asia. And it wasn't until Zika had a large outbreak in Yap in the islands of Micronesia that it was really kind of identified as a pathogen potentially to be concerned about. Still no real kind of concerns about microcephaly or other complications. And then in 2013, there was a large outbreak in French Polynesia as well. And it wasn't until Zika officially hit Brazil in 2015 that people started to get worried. In hindsight, we actually think Zika arrived as many as 2 years earlier, early into 2013, which I'll talk a little bit about. But you guys may remember some of these maps here that show these kind of outbreaks of Zika in different regions of Brazil, especially the northeast area, and then this connection with microcephaly. And once Zika arrived in Latin America, especially in Brazil, it was only a matter of time before it was going to spread elsewhere. And so this map here shows the orange areas where the vector, the Aedes aegypti vector, is endemic all year round. And these circles represent the number of travelers from Brazil to each of these different cities. And so the biggest circles here, which you can see in Orlando and Miami, represent more than 300,000 travelers per year. And so you can see these circles spread all over Latin America, including many areas where this vector is present. It was really not only a matter of time before we started seeing cases in other parts of Latin America. And that's true also for the United States. And so here you have in the pink at the bottom is where the Aedes aegypti vector lives all year round. The circles represent the number of travelers coming from Zika endemic areas. And then these little brown areas are where we've had previous outbreaks of dengue and chikungunya. And so using this data, you would probably predict that the places most likely to have Zika in the U.S. would be southern Texas and southern Florida. And in fact, that's exactly where we saw endemic circulation of Zika in the United States. And so using this kind of data can be really helpful to predict where Zika and other pathogens will show up. So here is where the current countries where Zika is thought to be endemic. The U.S. doesn't have any ongoing circulation of Zika right now, but we're, as you'll see, kind of primed for continued circulation in the future. And then otherwise, almost half the world is basically endemic for Zika at this point. And there's a lot of overlap between Zika, dengue, and chikungunya, as we'll discuss. Okay. Oops. Okay. So this shows an incidence map of reported cases of Zika according to PAHO. And our peak was really back in 2016. And we know that this is just a small portion of the overall cases. And in fact, there were millions of cases of Zika in Latin America during this time period. But it does give you an overall trend of what's been going on with Zika. And you can see that the number of cases in 2017 are way down. And that's despite having an improved surveillance system to detect Zika in most of these countries. But one important question is how low is low enough? And so as we'll talk about, when you have pregnant women making decisions about traveling to these countries or women living in these countries with endemic Zika circulation, there's always going to be this low-level risk. And even within a country like Mexico, for example, one area might have a high transmission rate where other areas have lower transmission rates. And so it gets really complicated making these types of public health decisions when you have this virus that can have such devastating complications, even when it's at a low circulating level. And we think that we'll probably continue to see low-level circulation of Zika throughout Latin America in the coming years. And so for these next few slides, I really wanted to take a step back and talk about why Zika seemed to hit us in Latin America like it did, why it spread so rapidly, and why we were so unprepared to really handle some of the complications. And one of the biggest categories was actually kind of environmental risk factors. And so this was supposed to be a really awesome embedded video that would show all the air traffic in a single day. But really, travel was a big issue in bringing Zika to Latin America and also spreading it throughout Latin America. And that's true for a lot of these emerging infectious diseases. When you're talking about SARS or MERS or Ebola, in the past, when a disease would take years to decades to travel across the globe, now it can travel in a matter of weeks to months. And so that was definitely the case with Zika, and it's probably something we'll continue to see going forward. Urbanization is a big ongoing factor for many of these vector-borne diseases. Here you can see a housing community in Brazil that's kind of impinging on the jungle. A lot of these zoonotic illnesses or arboviruses have sylvatic transmission cycles. So they're actually transmitted among non-human primates within the jungle. And when humans encroach on those populations, you could actually have spillover into the human population. Then you get outbreaks of disease. And that's happened with yellow fever and a lot of other emerging infectious diseases. And then finally, in 2015, this was a year when we had a big El Nino phenomenon. And during these El Nino years, warm surface water is actually pushed towards the western coast of Latin America, and that actually causes temperatures and precipitation to rise. This shows a map of the percentile of temperature during this time period, and this darkest red color is 90 to 95th percentile temperature. So this is a really hot year in South America and as well as North America. And it was also a really wet year. So the green here represents the 90th to 100th percentile for precipitation. You can see that many areas of South America had increased precipitation this year. And so these are big factors in allowing more mosquito vectors and therefore more transmission of Zika. And so all these factors came in to kind of make us ripe for a big outbreak of Zika. Immunologically, there were a number of factors as well. So this population had never seen Zika before, and so they were going to be highly susceptible to infection. As I mentioned, this area is very suitable for Zika transmission, but none of these individuals had previously been infected and therefore had no pre-existing immunity, as opposed to South Asia, where we've had maybe some protection from Zika, as well as maybe some cross-protection from dengue, which we'll talk about. And then finally, there's this important concept called antibody-dependent enhancement. And so this is a really well-known phenomenon with dengue infection. And just kind of real briefly, so dengue there's 4 different serotypes, 1, 2, 3, and 4. And when you get infected with the first dengue serotype, so serotype 1, you develop really good antibodies against that serotype for the rest of your life. Over the next year or two, you actually have pretty good antibodies against the other serotypes, so serotypes 2, 3, and 4. But over time, those antibodies start to wane, and if you get another dengue infection about maybe 4 years later, those antibodies against that second dengue type will actually bind, but they don't neutralize the virus. Instead, what they do is they facilitate the virus up into the cells and help it replicate more, so you actually have greater viremia and people get more sick. And that's why you get more sick when you have your second dengue infection compared to your first dengue infection. And we'll talk a little bit about this when we talk about Zika vaccines and dengue vaccines. But one theory as to why Zika spread so fast in Latin America is that we have this low-level dengue circulation throughout the entire continent. And when this new flavivirus comes in that actually looks a lot like dengue, in fact, some people call Zika the 5th serotype of dengue. It's possible, or one theory was that this low-level antibody actually caused enhancement of disease, greater viremia, and that allowed it to transmit faster when mosquitoes were biting people and transmitting greater viral loads amongst the population. So that's one theory as to why Zika was transmitted more rapidly. That was very hard to prove, and at this point it's going to be hard to kind of show if that was really an issue or not. And finally, whenever you have a new syndrome or a new pathogen, you always wonder about mutations in the virus. And so Zika is an RNA virus, which means it has to reverse transcribe to become a DNA before you can start replicating. And so this process is actually very prone to develop mutations. And we've seen that a lot with dengue as well as other RNA viruses like chikungunya. And in fact, chikungunya had a mutation that allowed it to be better adapted to one of the mosquito vectors, which is one factor as to why we saw this large outbreak of chikungunya several years ago. And so with Zika, since we know this association with congenital or microcephaly, there was always this concern that maybe this strain of Zika in the Americas was different than the one that we had previously seen in Asia and Africa. And there have been a couple of interesting papers that came out recently that kind of go into more detail and seem to point out that there probably was a mutation going on. And so this study here looked at a control population as well as a Cambodian strain of Zika and the Venezuelan strain of Zika. And they looked at microcephaly in mice and found that the Cambodian strain was actually put you at risk for microcephaly compared to a control, but the Venezuelan strain was actually worse than even the Cambodian strain. And so there seem to be some changes in these strains over time that makes it more neurotropic and more likely to cause microcephaly in this mouse model. And here's some histology slides of the mouse brains. The green shows Zika-stained cells, and you can see that the Cambodian strain had some Zika activity, but the Venezuelan strain had significantly greater Zika activity, and this is also represented here in this figure. This group took it one step further, and so they found the same findings, but they also went back and sequenced the Zika virus from Venezuela and found that there were a number of mutations that had developed between that one and the previous one in Cambodia. They then took these mutations and inserted them into a wild-type mouse that was unlike the other Venezuelan Zika strain. So this was a kind of a normal Zika strain which they inserted this new mutation into, and they did that with each of these individual mutations that they found, and found that when they infected mice, this single mutation here, the S139N, led to significantly greater mortality. And so it seemed that this mutation was putting these mice at increased risk for mortality. When they deleted the mutation in these same mice, they found that these mice actually survived better. So this single mutation seemed to have an effect on these mice. When they infected pregnant mice, there was an increased risk of microcephaly as well compared to the wild type. They then went back and used a phylogenetic analysis so they can look at the number of mutations that develop over time and look at different Zika strains in different areas, and they could estimate when new mutations arise. And looking at doing the phylogenetic analysis on these mutations with Zika, they estimate that this new strains emerged sometime in 2013, which is right before Zika hit Latin America. So it seemed like the timing fit pretty well with this kind of outbreak in Latin America, as well as this new finding of microcephaly that hadn't been described before. And then finally, one of the big issues that I think really left us on our heels during this outbreak was a lack of surveillance to pick up Zika, as well as some of these complications. And so one of the problems with Zika is it looks just like dengue and it looks just like chikungunya. So symptoms are rash, fever, body aches and pains. I mean, that pretty much describes 90% of illnesses out there, especially viral illnesses. And in fact, Zika looks so much like dengue and chikungunya that if you send a specimen to CDC to get tested for Zika, they'll also check for dengue and chikungunya. And so if the CDC doesn't think you can tell it apart clinically, you probably can't really tell it apart clinically. Another problem with Zika is that 80% of infections are asymptomatic. And so if you're even just looking for the symptomatic infections, you're only going to be picking up a small portion of all the cases of disease. And here's just some pictures of kind of the clinical findings of Zika. So this kind of maculopapular rash, red eyes without purulence, and some of these other lesions that you typically see. But these are seen in a lot of infections, including many viruses, especially dengue and chikungunya, leptospirosis, measles, and so it's really hard to kind of clinically make a diagnosis of Zika. The other problem is that Zika is transmitted by the same vectors as chikungunya and dengue. And so if you're in an area of Brazil that has lots of dengue and chikungunya that has the same vector, and all of a sudden you start seeing cases that look like dengue and chikungunya, you're not really going to be able to pick up on it. This is a new pathogen. And that was one of the major factors as to why we didn't really pick up on Zika despite thousands and thousands of cases going on in northeastern Brazil. This is the Aedes aegypti mosquito. So this is the primary vector for Zika. and the Aedes albopictus mosquito, which does not transmit Zika as well, but it has a wider geographic distribution, including into the United States. And so if Zika ever acted like chikungunya and adapted better to this albopictus mosquito, we might have more cases of Zika in the United States. Both these mosquitoes are domesticated mosquitoes, meaning that they've adapted to live near humans. And so really all they need is a small little cup of dirty water to lay their eggs. And so they're really hard to get rid of. And it's a kind of a common theme we're seeing as some of these vectors adapt towards crowded human populations. And this just shows the geographic distribution of the Aedes aegypti vector, which, as you may remember from the previous slide, is very similar to the distribution of Zika, dengue, and chikungunya. One new thing about Zika is that this is the first arbovirus that's been known to be kind of well transmitted through sexual transmission. It really is just a small portion of infections, and there's been ongoing studies to figure out what the real risk is. But so far, we know that Zika could be transmitted from male to female, from female to male, from male to male. It could be transmitted from asymptomatic infection. So if someone's asymptomatic, they can transmit it to their partner. And in fact, the first case of Zika in the United States, and the first sexually transmitted case, was reported from an incident in 2008 when someone from the CDC came back to to Fort Collins and transmitted it to their partner. And so we've known about Zika in Colorado for a long time. Currently, the CDC recommends, based on some data down here, which I'll talk about, that women wait at least 8 weeks after being exposed to Zika to attempt conception, and that men wait at least 6 months. And the main reason that men have to wait longer is that there's been a number of studies that have identified Zika RNA in semen up to 188 days afterwards. There's actually some unpublished data that suggests in some individuals it's lasted even longer, up to even a year. And they've actually demonstrated transmission of the virus up to 69 days after potential exposure. And so this is pretty concerning. Just finding RNA in your semen does not mean you're finding active virus. And so as we get more data, hopefully this 6-month window, we might be able to wean that down a little bit. So it wasn't really until microcephaly was being identified in Brazil that people really started to kind of raise red flags about Zika and actually recognize that Zika was a big problem in Brazil. So in the end of 2015, based on not very good surveillance systems, mostly passive reporting, Brazil realized that they had a 20-fold rise in the number of microcephaly cases in their country. So a total of 5,000 cases were reported. Because the surveillance system wasn't very good, the estimated risk was anywhere from 1% to 13%, and these are mostly in the first trimester. Now that we have studies that are ongoing that are trying to collect the data more systemically, we know that at least in the U.S., for example, we think that pregnancy risk of Zika resulting in congenital Zika syndrome is about 4% to 5%, which is a little bit lower than what was previously reported, although this data doesn't take in consideration miscarriages. Also, some interesting findings from the U.S. data is that you can actually get congenital Zika syndrome if you get Zika during any trimester. At first, we thought it was just the first trimester, but really, even in your third trimester, you can develop complications. And also, asymptomatic women seem to be almost as high a risk as symptomatic women as far as transmitting Zika to the fetus. And you would think that it would be very easy to pick up a Zika-affected infant compared to a non-infected infant, but not all cases of Zika are so obvious. And so if you have a baby with a head circumference of only 31.5 centimeters and the cutoff is less than 32 centimeters, and the baby's otherwise completely normal, you may not bring that baby in to get checked out by the physician and have their head circumference measured. But if you are in an area where there's known Zika transmission, there's lots of public health messaging to bring your babies in, you're much more likely to pick up that case. And so the case reporting varies a lot depending on what's been going on. And especially in northeastern Brazil, as people became more aware that Zika was an ongoing problem, it's possible that kind of falsely elevated the number of cases that were being reported. And data out of Colombia, for example, identified much fewer cases of microcephaly. And so there's a lot of discordance as far as the rates between different countries. Another problem is that people were using many different case definitions. And so this is some data from our site in Guatemala where we went back and looked at data that we collected from a registry prior to Zika arriving at our site. And we looked at head circumferences that we collected, and we looked at different case definitions that have been proposed or used by different countries at different times. As you can see, there's a lot of different case definitions that have been used, and each one has subtle changes between one and the other. But an important finding was that the rate of microcephaly in our population varied dramatically depending on what case definition we use. And so If you use one case definition down here, the rate was 4.4% of all babies born. But if you use this first case definition that was used in Brazil, as many as 42% of the children born in this area have microcephaly. And so when you have these different case definitions being used in different countries or even different populations within the same country and over time, you're going to have very wide discrepancies in the rates of microcephaly. And that was one problem in understanding what the real risk was of this important complication. And so, as you may remember, one thing I mentioned is that with this mutation, we think it probably arose sometime in 2013, and we think Zika really hit French Polynesia in 2013. And so, why didn't they pick up on this microcephaly thing? We know the island had 270,000 people. They did some studies that identified, one study was a serosurvey where they went on and randomly tested people for Zika. Another study used modeling and identified up to 94% of the population as being infected with Zika, which is pretty impressive. But whatever strategy you use, you would expect that we would have picked up on some cases of congenital microcephaly in this population, given the number of people that were infected, but this wasn't reported. But in hindsight, some researchers went back and used previously collected data kind of retrospectively and identified 19 cases of microcephaly, which was a huge increase compared to what the data had shown previously. And so basically, we weren't looking for Zika or for congenital microcephaly, and therefore we weren't picking up on it. And so this was the first time that a congenital birth defect has been associated with an arbovirus. And so it just wasn't on people's radar. And if you don't have a good surveillance system in place, you're not going to be able to pick up on something like this. And so it wasn't until we really started noticing this giant outbreak in Brazil of Zika as well as congenital microcephaly that this connection was really made. And so I like these photos here. These are both from French Polynesia. This shows French Polynesia if you're only at the surface, but if you actually dig a little bit deeper, it could be a pretty scary place. And that's kind of what was going on, I think, with this congenital Zika syndrome at the time. So while the microcephaly complication was fairly obvious, we are kind of realizing now that there's a lot more to this than just microcephaly. And we can learn a lot from Zika from previous congenital viruses like CMV and rubella. With these two pathogens, we knew they caused microcephaly and blueberry muffin spots, which are kind of common and obvious findings that you would learn about in medical school and pick up on pretty easily when the baby's born. But it wasn't until careful studies were done that we really realized that there's a huge spectrum of disease with these other viruses. So things like seizure disorders, chorioretinitis, calcifications in the brain, and even sensory neural hearing loss. Those things took years to kind of really figure out. And even with rubella, it wasn't until these children reached school age that we did these longitudinal studies that we were able to pick up on very subtle things like learning disabilities, ADHD. And so I think there's a lot of lessons to be learned from these previous pathogens. And so far, we're finding that that's the similar situation with congenital Zika syndrome. So microcephaly was kind of just the tip of the iceberg. We found a number of other complications here as well, things like feeding difficulties, hearing loss, ocular abnormalities. And we really won't know until these kids reach school age, and we do carefully kind of done longitudinal studies that we might be able to pick up on some of these subtle learning disabilities and things that we've seen with previous infections like rubella. So the story will take several years before we really kind of understand the full spectrum of developmental outcomes of Zika. But so far, I mean, even with these complications alone and the burden of Zika during these last few years, there is a whole generation of kids that are going to be affected by Zika, and it's going to take a lot of carefully done studies to really appreciate the impact on this entire generation, including some of these more developmental, subtle defects. Another big question that's come up is, what about infants and children? And so we know that the brain develops quite a bit during pregnancy, but the brain continues to develop quite a bit after pregnancy. And especially in this first year of life, you're developing sensory pathways like vision and hearing, which we know can be affected by congenital Zika syndrome. Language, as well as higher cognitive functions, are often kind of important early aspects of neurodevelopment. We also know that, at least in adults, there have been a number of case reports of neurologic complications such as hearing loss. And so a big question is, when infants, especially young infants, get infected with Zika, is there any risk of developing disease? And that's actually our main study that we're doing right now in Guatemala. This is an NIH study where we're enrolling 1,200 children, including 500 infants. we're getting a lot of baseline data, so including their baseline serology against Zika, dengue, and chikungunya. We're doing other developmental testing. In this case, we're using Mullen's testing, which is similar to the Bailey's in some ways. We're doing hearing tests, vision tests, and then we're following these children over a year, doing active surveillance to find out if any of these kids develop Zika infection. And we're also doing developmental testing over the next year. So every 6 months, we're doing a Mullen's test as well as hearing tests, vision tests. And at the end, we'll have this group of infants and children that have acquired Zika infection during this 1 year period. And then we'll be able to compare in those Zika infected versus the non-infected if there's any impact on their developmental level, as well as their vision and hearing. And so we hope at 2 years, at the completion of the study, we'll have a better understanding if Zika poses a risk to infants and young children. As you can imagine, this has huge implications for families in the U.S., for example, that want to travel to Cancun on vacation for spring break. Should they bring their infants and children along or not? And so we'll have a lot more data in a couple of years, but it's an ongoing study that we started in June, and hopefully we'll have some interesting findings, but not bad ones for the children. And so kind of moving on, one of the big problems with Zika is that it's actually very difficult to diagnose. And so if you could pick up a case of Zika early on, it's actually pretty easy. So I mean like in the first 5 days, maybe up to 2 weeks. And the reason is that you could use a PCR test or an antigen test where you're actually picking up virus in the person's body or in their blood or serum or urine. And in that case, if you have a positive test, it's really reliable. There's a lot of tests that are being developed right now. This is an example of a nice test that we were involved in validating. It's basically a Zika NS1 antigen test. And so the way this test works is you take a blood sample, you put it here, and it acts kind of like a pregnancy test where it uses lateral flow chromatography. So it gets pulled across this strip, and then if the Zika antigen is present in the blood sample, it'll light up in this one area. And you can use things like smartphones to get a kind of more controlled answer of a positive or a negative. But this is a nice kind of test that could be done potentially in the field once it's validated and approved for use. It's also only going to cost about $2 to $3. And so this is the type of test that people are developing right now to pick up on Zika in these communities. There's a lot of other tests that are being developed as well, including one using CRISPR, which is kind of a really interesting study, which I don't really have time to go into. But there's a lot of tests that are being developed right now to really that are helping us identify Zika early on in the course of disease. The problem is that once you get beyond that first initial period, when the virus is no longer in your body, that's when you really have problems. And so at that point, you're relying almost entirely on antibody tests, and so IgM and IgG tests. The problem with these tests is that they cross-react like crazy with other flaviviruses. And so Zika and dengue, as I mentioned, are very similar. People call Zika the 5th dengue serotype. And so when you have a positive antibody test against Zika, you don't know if that antibody is really against Zika or if it's actually against dengue. And that has huge implications for a lot of populations. So, for example, a pregnant woman that has a dengue infection maybe has some risk, but not nearly the amount of risk that they might have from Zika infection. And so when you have a positive test using like an ELISA or kind of the more available technologies, you can't really rely on that. And so then you have to move on to this other test called a plaque reduction neutralization test. And as you can tell by the name, it's probably a really complicated test. So here you have to grow virus, and then you got to take different concentrations of the patient's serum and then put that in each one of these wells and see how well the virus grows at these different concentrations and see which one gets neutralized. And so as you can imagine, that's a really expensive and time-consuming test, and it's not really feasible in most Zika endemic countries, which are largely kind of resource limited. The other problem with antibodies is that we don't know how long they last. And so antibodies typically appear at 5 to 7 days, and they can last anywhere from 2 months to 4 months to 6 months in some cases, and even longer if someone's immunocompromised. And so if you have a pregnant woman coming into your office that has a positive IgM test and they've been pregnant for about 1 month, you don't know if that infection occurred before they're pregnant or while they're pregnant, and that has, again, big implications. And so as you can imagine, when you're trying to think of a way to screen pregnant women in these Zika endemic areas, you're really running into a lot of problems here. So keep in mind that most Zika infections are asymptomatic, so you're going to have a hard time picking up on these people when they're first infected. So you can't rely on those PCR tests or those antigen tests that will really tell you that their Zika is in their body and it's a reliable positive test. These antibody tests then are the ones that you're going to have to rely on, but you have a lot of false positives. And so if you can get this PRNT test, it's going to take weeks and weeks to get your answer back. And as I said, most Zika endemic countries don't even have that testing available. So if you can't really act on a test, what's the point of even doing it? The other problem is that there's lots of pregnant women. So we have hundreds of thousands of pregnant women in the U.S. There's millions in Latin America. So how do you come up with a large-scale surveillance system where you can actually screen these pregnant women and really make the right call as to whether they're truly infected or not? And so these have huge implications from a public health standpoint. And as the Zika kind of endemicity is changing over time, it's constantly in flux. And just as an example, the CDC recently changed their screening recommendations for pregnant women in the U.S. So now they actually recommend against screening asymptomatic pregnant women in the U.S. that have traveled to a Zika area because the prevalence is so much lower now, and the risk of having a false positive test increases with that. And so now the CDC is actually getting more false positive tests than true positive tests. And so how do you deal with that from a public health standpoint? It actually gets really complicated. And so instead of kind of going through all the different situations, I think the best thing for me to do in this talk is just to kind of refer you to the CDC for if you have specific clinical situations that you're wondering about. And so they have really nice algorithms that they constantly update on how to deal with different populations. And just as an example here, this is their recommended Zika testing algorithm in asymptomatic pregnant women. So this would be a woman that traveled down to Guatemala, for example, came back, realized they were pregnant. What do you do as her physician or provider and what to do? And this is what these algorithms look like. They kind of walk you through exactly what you're supposed to do. And the nice thing is these algorithms get updated whenever the new recommendations come out. And so you can access these through the CDC or also through the Colorado Department of Public Health. I just want to make sure I'm not going over. Okay. So now we're being slow. So one of the biggest issues then, of course, is how to prevent Zika. There aren't many treatments, which we'll talk about. And so right now, the only ways of preventing Zika are actually to avoid Zika. And that includes avoiding travel to these Zika endemic areas if possible. Obviously, the people living there aren't able to avoid travel, which is a large public health problem. But once you're in these settings, using things like air conditioning, long-sleeved pants, insect repellents, these are the ones that are approved by the CDC. Wearing condoms to prevent sexual transmission, and mosquito control are all important aspects. One kind of interesting part about Zika is this whole issue of sexual transmission. That raises a whole new element to kind of public health surveillance. And so you can imagine in the United States, if you have all these Zika endemic areas in southern Florida, Texas, Arizona, and you have people coming back from Latin America into these areas, if they are Zika infected, they could transmit it to a Egypti mosquito, but they could also transmit it to their partner, who can also transmit to a Zika or to the vector, and then create a local kind of epidemic. And so this new method of transmission has really raised another kind of complication for public health officials are really trying to prevent Zika transmission. And so it makes it a lot more complicated. I know a few people that got Zika, and when they returned to the United States, they were being called by the state health department basically 3 times a week, asking if they've had sexual encounters and treating it more like a sexually transmitted infection as opposed to the typical vector-borne disease that we usually would think about. But it really complicates kind of public health measures to control and prevent outbreaks within the United States. And so while preventing mosquito bites is really the main issue right now, there are a number of vaccines coming along, and this will be really our kind of main way of preventing Zika going forward. And again, there's a lot of lessons that we can learn from previous congenital infections, and rubella is a great example. So as I mentioned, congenital rubella syndrome looks a lot like congenital Zika syndrome. You kind of see all this large spectrum of complications. And back in the 60s, as many as 50,000 women that were pregnant were exposed to rubella each year, resulting in 20,000 infants born with congenital rubella syndrome. And that's quite a large impact in the U.S. alone. As we know, the MMR vaccine was introduced and actually has reduced rubella infections basically down to 0. We now just see a handful of imported rubella infections every year, and that was a pretty dramatic impact. And while we still see about 100,000 or so rubella cases globally, having a strong vaccination campaign that with a big public buy-in really reduced this risk down to the U.S. Down to 0. And I think we could probably achieve a similar thing with Zika. As we'll talk about, a lot of the vaccines are looking pretty promising. Another nice thing is that we have a lot of experience with flavivirus vaccines at this point. And so yellow fever vaccine has been around for decades. We know it has a high efficacy. It's relatively safe. And you get a pretty good protective titer. One problem with a lot of these vaccines is we've often relied on antibody titer as a correlate for immunity. One thing we're finding out with some of these more recent flavivirus vaccines is that might not be as good of a correlate as we originally thought. Other flavivirus vaccines, including Japanese encephalitis and tick-borne encephalitis virus vaccines, use an inactivated virus, and these have been shown to be effective, including a new JEV vaccine that was just licensed recently. There are a number of dengue vaccines under development, including one that's been licensed. This gets a little bit complicated, and we'll talk about that in a second. And then also there's some West Nile vaccines that are under investigation right now. And so we've been able to use some of these flavivirus platforms actually used for developing a Zika vaccine, and it's been really helpful moving the technology forward in a quick way. Another important thing for vaccines is you have to have a strong demand in order for vaccine developers to create the supply. And there certainly is a strong demand for Zika vaccine. And so this is a study that we did in our site in Guatemala where we surveyed a little over 500 households. And in general, there was a really high concern for arboviruses in general. Interestingly, the community at the time was actually most concerned about chikungunya virus. And I didn't really talk much about it, but one of the complications of chikungunya is that you can actually develop really severe long-term arthritis and arthralgia. And in a community that most people actually use, their occupation is some type of manual labor. Most of these people are farm workers, and they rely on using their hands and feet all day. Having a virus like chikungunya, which can result in these long-term complications that really affect their ability to work, has a big impact. And so economically, chikungunya was a huge concern in this area. And at the time we did this survey, it was even more of a concern than Zika and dengue. And I'd be curious to see how their concerns have changed over the last year as public health messaging is kind of reaching these communities a little bit more. But even despite that, there was still a strong demand for a vaccine for Zika as well as these other two arboviruses. So if you look at we surveyed these people about if the vaccine was only 50% effective or 75% effective, would you still want this vaccine? And still 75% and 85% of the population voiced an interest in this vaccine. Of course, this question was if the vaccine was free, but not all vaccines are free. And so we also asked about their willingness to pay for a vaccine. And this is one of the poorest areas of Guatemala. And despite that, as many as 16% of the population was willing to pay at least $6 for a Zika vaccine. And so I think there's definitely a demand, including for maybe a private market of Zika virus vaccine. But in general, what we kind of concluded is that most people will not be willing to pay for the vaccine. And so if a government wants to introduce it, they're going to have to pay for it themselves. And so based on this demand, there's a lot of vaccines in development. And these are the vaccines that are currently in clinical trials, with a couple of them in phase 2 right now. But there are many, many other vaccines that are still in preclinical development. And so over the coming years, there will be a lot of vaccines being introduced, and there will be a lot of competition to make these vaccines available and low cost, hopefully. There's a number of technologies that have been used to develop these vaccines. And so inactivated virus vaccines have been used for other flaviviruses. DNA vaccines is what the NIH is using, mRNA vaccine. A number of these new technologies that have only recently been developed have been very useful in kind of using those platforms to rapidly develop Zika vaccines. And just to give you a sense of how fast these vaccines are being developed, most vaccines take a decade or more to be developed. The Zika vaccine is the complete opposite of that. It's one of the few times where all the pieces come together and really kind of move things forward. So just kind of give you a sense of the NIH's DNA vaccine development. So the vaccine, the NIH first received their Zika isolates in January 2016. By April, so 4 months later, they had sequenced these different isolates and came up with the sequence that they wanted to use for their vaccine. By August, they had started phase 1 trials in humans of their vaccine, then a second phase 1 trial of a different strain in December. So within a year of getting their Zika shipped up from Brazil, they were actually testing out a vaccine in humans. And that's kind of unprecedented as far as vaccine development goes, and kind of really impressive, and I guess a test to the collaborative atmosphere that's been going on with Zika. This is just some data from non-human primates of a specific NIH vaccine, which is the one that's furthest along. They looked at a number of different strains, and this is the one that seems to be the most promising, showing that they developed a strong neutralizing antibody response using different concentrations of the vaccine, as well as suppressing viral load. So these primates did not develop a viremia as opposed to the control or some of these other isolates. As I'll talk about, there's a lot of issues with these Zika vaccines, and they relate in a lot of ways to the dengue vaccines. One of the important aspects is that you need to have a high neutralizing titer. Here you can see that the primates that had a high titer were protected against disease. Those are all the gray ones. And the ones with the red or the low titers had a developed disease. And so you want to have a high neutralizing titer, but you also want to have a titer that persists. And so if you're protected against Zika vaccine for a year or two, that's not very helpful for a woman that could become pregnant 3 or 4 years later. And so one thing that will be really important moving forward as we do these phase 3 and phase 4 clinical trials is not just using Zika infection as the primary endpoint, but we want to assure that there's a prolonged protection against Zika for years down the road. And there have been some concerns with the dengue vaccines, which I'll talk about. This was a really interesting study that just came out this last month. And this is kind of a human trial of human infection model of Zika and the Zika vaccine. And so in this study, what they did was they they gave humans this Zika vaccine that's been developed. Then they took serum from the humans at day 0, so before they got vaccinated, and also at week 14. Then they gave this serum to humanized mice. And so they took these antibodies from the humans, gave them to the mice. And here you can see that when the mice were given the serum at baseline, so day 0, so these humans were not given the vaccine yet against Zika, and then these mice were infected with Zika, they all died relatively quickly. But when the mice were given the serum from these humans that received the vaccine, so in other words, this serum had neutralizing antibodies in it, these mice were protected against Zika going forward. So this is kind of a nice way of doing like a human challenge model of Zika virus and seeing how well the vaccine works without actually infecting humans with Zika. And this data, I think, is kind of more promising data to support this NIH DNA vaccine that's being developed. And just to kind of give you one more glimpse of how fast this is moving along. And so this is how the NIH is going to be running their phase 2 and phase 2B trial. And so usually what you do for a vaccine trial is you have your different groups, different increasing doses of the vaccine, different kind of ways of giving the vaccine. And then you enroll these subjects, you follow them for a certain amount of time, and once you're satisfied that it's safe in that population, you move on to the next group. And as you can imagine, that can take years to kind of conduct that type of study. In this study, they're actually overlapping these groups. And so before they even finish their part A, they're going to have an interim analysis. And if their interim analysis suggests that this vaccine is safe, they're going to move on quickly to their phase B, as the first part is continuing to follow up on these patients. And so they're going to move this along really quickly. They also have over 20 sites in Latin America to do the study and enrolling, for this part, at least healthy adults. And so in a very short amount of time, we're going to have a lot of data on safety, and they're trying their best to kind of ensure that the vaccine's safe while not limiting the timeline of rolling this vaccine out to the population. One issue for these vaccine trials is going to be that there aren't that many cases of Zika right now. You remember that prevalence graph I showed you, the number of cases of Zika in 2017 is down a lot. And in order for you to do a phase 3 or phase 4 trial, you need to have Zika cases to be able to detect the difference. And so one of the problems they're probably going to run into is that they can give this vaccine to 10,000 people, but if they're not picking up enough Zika cases, they won't be able to show if the vaccine is really effective or not. That was the same problem they ran into with the Ebola vaccine. Again, they rolled it out really quickly, but by the time the vaccine was available, they weren't able to have enough cases to really detect an efficacy or not. And so they used this alternative trial design where they used ring vaccination. And so they took people that had Ebola and they vaccinated those people around them and saw how well it worked in preventing those people from getting infection. So it was a way to identify more at-risk people and seeing how well the vaccine worked. And so we'll see what happens with these vaccine trials with Zika. It depends a little bit on what happens going forward. But there are some strategies that they might be able to employ to see if they can prevent that. So just a couple lessons learned from the dengue vaccine. So right now there's one licensed vaccine available It's produced by Sanofi. And there are some concerns on the data that's been made available so far. And so two issues. One is that the vaccines seem to be less effective in younger children. So here you can see that in older groups, the vaccine group had a lot less dengue than the non-vaccinated group, and that was statistically significant. But when you get into this younger population, that risk decreased or increased, I guess. So they were less protected against getting dengue. Similarly, if an individual was already had dengue in the past, so if they were seropositive for dengue at enrollment, and then they got their vaccine, the vaccine worked pretty well. But if they weren't seropositive at baseline, there was no statistical significance. And so basically what this suggests is that the dengue vaccine acted well as a booster. So when you get your second, if dengue vaccine counts as a dengue infection, when you get that second dengue infection, you're boosting your immunity and protecting yourself. But when the vaccine counts as your first dengue infection, those individuals didn't seem to have as big of a benefit. And as you might be able to imagine, that's concerning because when you have a second dengue infection, that's when you get most severely ill. And so if you have a completely naive population, for example, and all of a sudden you give them the dengue vaccine, they develop some antibodies against against dengue, then they get their first real dengue infection, they actually get more severely ill. That's actually a complication of the vaccine itself. So you're actually increasing the risk that these people will develop more severe disease. And so there have been a lot of questions about the Sanofi vaccine, about whether it's really safe or not. And so now they're collecting more longitudinal, long-term data on these individuals to see what that risk really is. But that raises important issues for Zika. So if you develop a Zika vaccine, and remember Zika is like the 5th dengue serotype, and you give this Zika vaccine to a huge population in Latin America, and we know that you might have some cross-protection against dengue, or some antibodies that cross-react against dengue. These people are probably protected against Zika for life, but then when they get their Zika or their dengue infection 2 or 3 years later, they actually might get more severely ill. And so there's going to be a lot of questions that come up with these vaccines about safety and long-term follow-up and what's the interaction between dengue and Zika, and there will be a lot of kind of unanswered questions. And this slide kind of just goes over this issue of antibody-dependent enhancement between this Sanofi vaccine and potentially Zika vaccines. And finally, there are some actual therapeutics that are being developed. So monoclonal antibodies have been studied in mouse models, and these antibodies bind to usually the envelope protein, and they've been shown to be effective in eliminating the virus from mouse models. There's a number of issues that are still ongoing, though, so these are, of course, very expensive. There's questions about safety, and so these studies are ongoing. This might be one treatment modality for pregnant women in the U.S., for example. So if you can eliminate that viremia, maybe you could protect the fetus from acquiring Zika. There's a number of drugs that are being investigated as well, and typically they're looking at drugs that will inhibit Zika virus replication, inhibiting these two non-structural proteins for the most part. And the first step was screening the FDA-approved drugs that have been approved already, because these are drugs that could be made available quickly. And it looks like about 3% of drugs have some activity against Zika virus in the lab or in vitro. 2 of them have been studied in mice that have some potential good data. Sofovir, which is a hepatitis C drug, had good activity against Zika in vitro, looked to be okay in mice, but it's actually very expensive and probably not going to be very feasible for large populations. And then one that I found really interesting was actually chloroquine. As we know, chloroquine is used to treat Plasmodium vivax throughout Latin America. It's safe, it's cheap, it's been around for decades, and it actually has some activity against dengue. And in this study, they looked at it in mice and found that compared to the control population, the chloroquine population had decreased Zika viremia, so it reduced the viral load at day 1, 3, and 5, and so it definitely had an impact on viremia. Another interesting thing they did was they gave it to pregnant mothers. They gave the chloroquine to the mothers, and then those mothers were breastfeeding the pups. Then they infected the pups with Zika, and the pups of mothers who had been given chloroquine were actually protected against Zika. And so it's kind of an interesting study and shows some of the potential uses for chloroquine as a treatment if it's shown to be safe and effective in humans. And so I try to give you kind of a rapid-paced overview of Zika and some of the issues that are going on with Zika. There's a lot that we're learning about Zika, as well as some of these emerging infections and some important issues that are we need to research going forward. So first off, one thing that we're finding even at our site in Guatemala is that neurodevelopmental delays or just developmental delays in many of these resource-limited countries is staggering. So far we've been conducting Mullen's testing on, we've done about 500 or so tests in our population in Guatemala, and the average Mullen's test is at least 1 standard deviation below ours, and in many areas at least 2 standard deviations below what we would consider normal in the U.S. And so if you expand that to Latin America and a lot of these other resource-limited areas of the world, that's huge. And there's a lot of reasons for that. I mean, there's malnutrition, there's anemia, but as far as development, I mean, it has a huge impact on your future success, your economic productivity as a country. And so I think Zika, in a way, has kind of highlighted this as a really important problem going forward. Another issue is that these countries don't really have the capacity to do developmental testing. And so I think it's kind of raised our awareness and our lack of ability to do these types of studies in these settings. And I think going forward, it'll hopefully raise our capacity to study neurodevelopment in many of these resource-limited countries. It's kind of put the spotlight back on some of these congenital infections that we knew caused problems during pregnancy in the U.S. and developed countries, but it's kind of re-highlighting them in resource-limited countries as well. Things like CMV, toxoplasma are things that we know cause problems in the U.S., and now hopefully this will get the gears rolling and allow us to study a little bit more in developing countries as well. We know that a lot of emerging viruses besides Zika are kind of being highlighted as having an impact on the developing fetus. And also we're better understanding the acceptability of vaccines, the demand for these types of vaccines in these resource-limited countries. And then finally, kind of child intervention programs. We're starting to dabble a little bit in what to do with these kids once we identify them in Guatemala in a resource-limited setting using whatever finite resources we have available. And so there's a lot of kind of important questions going forward. What's going to happen going forward in Latin America? What will happen back in Asia? Will this new Zika strain circulate back into Asia? There actually have been cases of congenital Zika syndrome in Vietnam now and other countries in Asia. What is the full spectrum of this iceberg? What are the other sequelae we're going to see? What are the more subtle developmental effects of Zika infection? What happens in infants that get Zika? What are the interactions with dengue, including with the vaccines? And so there's a lot of important questions that need to be answered going forward, and it's going to take years to really figure things out. So I would encourage the students and people in this audience to really kind of think about research questions going forward. So with that, I'd like to say thanks. I have a few minutes, I think, for questions, and started a little bit late. Thanks. These are some glamour shots from our site. This is our very large Zika team. We have 20 nurses, 3 or 4 physicians, so it's really kind of our first big project down there. Yeah.
How early can you detect Zika in an infant, and is there anything to be done at that point in time?
So the way they test for Zika in pregnant women now, one thing they do is actually they do a PCR test. And so one thing we found, or we've seen with pregnant women, if there is a congenital infection going on, so if the fetus is actively infected, the mother may not have much virus in her blood, but the fetus will actually is continually infected. And so they're actually spilling virus into the mom. And so if you test a pregnant woman 20 weeks after they're infected, you might actually have a positive PCR test because that infant's virus is spilling into the mom's blood. And so when the infant is born, you can actually test the infant and the placenta, and you will usually find Zika virus in there because the fetus hasn't been able to neutralize the virus, and so it's still actively infected, which explains a lot of the complications that are going on. And so you can actually pick up that virus really early in the infant. If you did an antibody test in the infant, the data might be a little bit more confusing. So we know that moms pass on IgG antibodies to the infant, so that test may not be very reliable, but if they have an IgM test, that might be more reliable that the baby was infected. Yeah?
So in terms of the prevalence, I know it's dropped off in the past few years, but have you looked at the effects of climate change?
Yeah, I mean, I know there's people looking at that. It's hard to really... I think one of the problems with climate change in general is that it's really complicated, and weather patterns changes. For example, El Nino was, if you were just looking at climate change, it's continuously change, going in one direction. But an effect like El Nino could really throw that off in a single year. And so there are people looking at different individual factors within climate change, like temperature, precipitation, how that affects Zika transmission or malaria or other kind of diseases. It's hard to kind of tie it all in together. But certainly as our planet gets warmer, that's going to affect precipitation. It's going to affect mosquito populations. And you're going to have more diseases like Zika spreading in new areas more aggressively, probably. Yeah.
Have there been any cases seen so far of enhanced second dengue infections following a Zika infection? That is, if you already have Zika antibodies, is that going to affect the dengue situation?
Yeah, so that's a really great question, actually. And I think so far the jury is still out. So they have shown that Zika can enhance dengue and dengue can enhance Zika going both ways in the lab. They've shown it in mice. I think they've actually had some data in primates that suggests that you can see it. There haven't been studies in humans that have looked at actual clinical worsening of disease. There just really isn't enough data. But I think one theory is that, as I kind of mentioned, that this low-level dengue antibody might have made Zika spread more rapidly in Latin America. When you get 3 or 4 dengue infections, you actually develop really strong neutralizing antibodies against all of them. And so you usually don't get disease if you get your 4th dengue infection, because your existing antibodies are enough that they probably protect you against that. And so if you look at a person that maybe had 3 or 4 dengue infections already, their antibody levels might be good enough, and their avidity or the quality of their antibodies might be good enough to actually protect them against Zika. So nobody knows those answers. But that'll be really interesting going forward. And for example, in Southeast Asia, where there's lots of dengue circulating, maybe that was some reason why they've seemed to be a little bit more protected against Zika as opposed to Latin America. So there's a lot of kind of questions about that, but that's a really good point.
Over there.
So for the vaccine development, if there's a potential that this disease morphs, do you think then you have a problem nailing down a vaccine, kind of like malaria, that it's not going to be very efficacious overall?
Yeah, so I think we learned a lot from dengue because it's a very similar flavivirus. And one question that's come out from some of these vaccine trials is that there's 4 different serotypes of dengue, but within each of these serotypes, there's actually different strains. And there's a lot of question as to, the Sanofi vaccine, for example, didn't work very well against the dengue 2 serotype. And it's been hypothesized, at least, that the dengue serotype 2 in circulating in these countries at the time was a strain that the vaccine didn't work really well against. And so you need to show not just protection against serotypes, but also against a diversity of strains. And so similarly with Zika, we need to know that the vaccine works against the current circulating strain, but these RNA viruses are constantly mutating. And so it's always possible a new strain will emerge that's different enough from the original one that the vaccine isn't going to be very protective. And of course, that new strain is going to have a selective advantage that the vaccine's not going to work, and that could actually kind of lead to more cases. So I don't think it mutates, it's not quite as complicated as malaria, for example, but it certainly is going to be an issue going forward, not just for Zika, but other flaviviruses, dengue, and even chikungunya, which is an alpha virus. Good question. All right. Well, I'm glad the enthusiasm is there for Zika, all these people here. Thanks again. And if you have any other questions, I'm happy to answer them up front or by email or whatever. Thanks.